Thank you. Okay, so I will start out by keying a bit off what Matt talked about and just kind of pose the question to start with. Matt talked a lot about causality and made the case for the importance of causal links. I just want to introduce the idea that maybe causality doesn't matter. The causal question in my training as an epidemiologist, we frame the causal question in terms of the counterfactual. So the counterfactual here is, what would the current outcomes of this nurse or nursing organization be if it were not credentialed? But that's a counterfactual problem because they are credentialed and you can't take away their credential. So that is a difficult problem to resolve, and classically we resolve it by randomly allocating people by conducting an experiment. And of course, that's a very difficult thing to do in the realm of credentialing research. But causality may not be the critical question if we're willing to accept credentialing as a signal or a correlate of higher quality and better outcomes. And as Matt suggested, there's nothing inherently wrong with signals. Markets need signals. So organizational credentialing, such as the magnet program, signals employers of nurses that have better nursing work environments. And that indicates to prospective employees that this is a good organization to work for. Organizational credentialing may also signal organizations that have better results so that they get more attractive terms, for example, in contract negotiations with health plans. Similarly, individual credentialing may signal employees who have more motivation and commitment, and that's a desirable skill in the workplace. So organizational credentialing can make healthcare markets more efficient. Individual credentialing can make the nursing labor market more efficient by making it clear what traits people and organizations have that should be rewarded in the workplace. So signaling is okay, but there are some problems with relying on signaling. So as Matt's talked about, credentials are proliferating, and we don't really know which ones are valid signals. So people, it's inevitable that people will try to ride on the coattails of programs that have been shown to be good signals. So if the magnet program, for example, appears to consistently be a good signal, then other organizations will develop magnet-like programs, but we don't know which ones are really valid signals. Each one has to be evaluated on its own. Similarly, we don't know the characteristics of credentialing programs that represent valid signals. So if we're relying on signaling, we really have to go much deeper to kind of figure out what makes a good signal. Furthermore, there's a problem that credentialing may not be feasible in all settings. So for some types of hospitals, some employees, there may be orphan domains that they're working in where there's no credentialing program available. There aren't enough nurses working in that field to sustain a program. Or there may be areas where organizations don't have the flexibility to free up their staff to pursue credentialing opportunities. And then, of course, as Matt suggested, it's really a question of public policy that if credentialing is a signal, then it's really a private good. In other words, the employees who pursue that credential will get more money. As a result, the organizations that pursue that credential will get more business in the marketplace. So there's no need for public investment in credentialing. So should public policy actually encourage individuals and organizations to pursue this credentialing process or journey? That does require some information about causality. And then finally, there's a concern, I think, that credentialing may be captured by a stakeholder group to the extent that it's just seen as a signal, and you go out and get that signal, and then you're all set. Then we've seen, for example, in California, this was in the news, I look at Joanne, but it turns out that, that police in many areas in California can get a credential for shooting straight. And if they win that credential, then they get a bonus. And that bonus translates into what we might call pension spiking. So this is a case where essentially a credential has been captured by the stakeholder group and no longer serves the purpose for which it was originally intended. So what if we understood the pathways? What if we understood better the specific nursing practices that improve outcomes? Now we could get away from all this debate about causation and signals and so forth, because then credentialers would know how to design their programs to optimize outcomes through these evidence-based pathways. And credentialers would need to demonstrate that their programs actually achieve those desired pathway effects. Markets would only reward the subset of credentialing programs that are able to demonstrate those effects. So if we understand those pathways better, then whether the relationship is causal or not, the credentialing programs will work better to achieve their intended purpose. Further, if we understood the pathways better, then employers could achieve, and patients being treated in those organizations could receive the benefits of credentialing in settings where credentialing isn't currently feasible or possible. And that in turn would weaken the power of credentialing monopolies and reduce the risk of capture. So there are a lot of advantages to understanding the pathways. The ANCC Research Council model, which we've seen, puts all of this in this box of intervening variables. And of course, that's not very helpful in itself. But what's interesting about this model is that these arrows here are non-recursive relationships. In other words, they're two-headed arrows. And that implies that, in fact, some of these intervening variables feed back and encourage people to become credentialed. And conversely, as patients experience better outcomes, then that may lead to changes in pathways, changes in the processes of nursing care, and that may lead to changes in credentialing behavior. So that's an important concept. Now, in the expanded conceptual model that Jack Needleman presented this morning, this is fleshed out a little bit more, and it's fleshed out in terms of three components, which is very helpful. One is about the performance of the individual nurse. What does the individual nurse do at the bedside or in the clinic? The second is about how nurses organize their work collectively in teams. And the third is about the architecture that supports that work, the climate, the culture, the leadership. And all three of those interact as these arrows suggest. So as we think about applying this conceptual model, here's a simplified representation of that. So we start with some kind of process. It can be anything. It can be education, experience, credentialing. This process leads to enhanced knowledge, that's testable, enhanced skills, that's testable, enhanced attitudes, that's evaluable. That in turn may lead to improved workplace behavior. When I talk about behavior, I'm talking about the observable features of what a nurse does in the workplace, how these work tasks are organized, and the architecture of the work environment, those three components that Jack described. And then finally, that may lead to earlier recognition and intervention, resulting in better patient outcomes. But this implies that there's a linear relationship, a continuum. And this is an example from the hospital domain of how this might work. So there's a lot of empirical literature, as most of you know, about the concept of failure to rescue. It was developed by Matt's colleagues at the University of Pennsylvania, Jeff Silber and Linda Aiken and others. And the notion here is that where high quality organizations and high quality nursing really makes a difference is not so much in preventing complications, but in identifying complications and rescuing patients who experience complications, so that the risk of mortality given a complication is reduced. So I think this is a concept that's been fairly well validated with many different data sets. And in fact, Jack Needleman and his colleagues demonstrated that, Peter Bierhaus and so forth, a number of years ago in a classic study in New England Journal. So this is how it might work. So a higher performing nursing organization or nursing workforce will promptly recognize warning signs and symptoms that patients describe. And my patient is having trouble breathing. They'll interpret those signs and symptoms as problems that threaten a patient's recovery. Her breathing is getting worse compared with my experience with other post-op patients. They'll collect the information necessary to engage team members and to facilitate decision-making. I'm going to go check a pulse ox. The pulse ox is down to 88%. They then communicate that information promptly and effectively to other team members. Bring in the physician, bring in the respiratory therapist. They'll often suggest specific diagnostic or therapeutic interventions. Maybe we should get an X-ray. Or they may work with the patient to improve their adherence with an intervention that's already been prescribed. They implement those interventions quickly and effectively. So when the X-ray has been ordered and the X-ray tech hasn't shown up for an hour, the high-performing nurse will get on the phone and say, what's going on here? We need that X-ray, right? And then when a medication order is placed, a high-performing nursing organization will make sure that those medications are available quickly at the bedside so that they can be administered to the patient. And then the high-performing nursing organization will evaluate the impact of those interventions in a timely and accurate manner. The albuterol seemed to help, it didn't seem to help, and communicate that impact evaluation promptly and effectively back to the rest of the team. So it's very much a process of coordinating, integrating care, communicating. It's a complex process. And the fundamental problem, we have a couple of problems. One is that the causal pathways are very complex. This can be mapped out. This is a causal diagram. And this is a type of causal diagram that in the epidemiologic tradition is called a directed acyclic graph, or DAG. It's directed because it ultimately goes from one place to a different place. So in this case, it goes from knowledge and skills up at the top through various behaviors down to outcomes. But notice, this is a grossly oversimplified DAG, and yet it's still pretty darn complicated. So different knowledge and skills contribute to different behaviors, which all contribute to different outcomes. And so in some cases, one behavior leads to several outcomes. In other cases, several behaviors lead to a single outcome. Sometimes we need to think of causal loops. So there may, in fact, be feedback loops where the adoption of a practice through, for example, word of mouth is a reinforcing process, whereas a practice gets adopted, then more and more people say, hey, that's a good thing, and it leads to an exponential growth in the practice. On the other hand, there's a balancing loop where as you reach a saturation point, there are fewer and fewer potential adopters who are still out there to adopt the practice. So there are causal pathways, causal loops. So we have some methodologic challenges. These are complex, easily oversimplified. Knowledge and attitudes don't necessarily translate to skills and abilities of the front line. Most nursing work is poorly documented in the medical record, let alone in coded data. And I've shown, if you think back to that slide on failure to rescue, how many of those things on that slide would be clearly documented, even in the best electronic health record system, even in Cerner's system or the EPIC system that I use. We need hierarchical multi-level models to link patients with individual nurses, with nursing teams, to adjust for unit level, nurse level, and patient level factors simultaneously. And then attributing and partitioning this variance and outcomes requires very large data sets. But there are some opportunities. So I'll end with some thoughts about some of these opportunities. So with electronic health records, we do have the ability now to link patients' episodes and individual clinicians, including both physicians and nurses. With credentialing-based wage premiums in many organizations, now there's a business case for being able to link that business information with the EHR so we can find out which nurses have which credentials. There are increasingly useful audio tape, videotape, and direct observation methods that really provide a gold standard for assessing nursing processes in real-world settings. How much time do nurses really spend at the bedside? And what do they do? The International Classification of Nursing Practice has been adopted by the WHO's Family of International Classifications, harmonized with SNOMED CT, and it offers pre-coordinated concepts. So you can now watch a videotape, and you can code the therapeutic activities of nurses. And you can say that this nurse spent 1 minute and 45 seconds educating a family about pain management. So these tools are available. Oops. And we also have an increasingly sophisticated set of analytic methods, dare I say, too sophisticated for me, but they're still very useful tools to relate these concepts. So latent trait and class analysis allows us to relate observed variables like credentials or experience to underlying latent variables that aren't directly measurable, like the quality of nursing care. There's no necessary statement about causality there. The findings from this type of analysis can be validated using actual patient outcomes to help us understand how these measurable characteristics relate to through the latent variables to the outcomes of interest. And there's an increasingly broad set of tools under the broad category of structural equation modeling that can incorporate both latent variables and causal dependencies between exogenous and endogenous variables. Path analysis is one common term for that. And these methods allow estimation of both direct and indirect effects of specific training or processes. They also allow modeling of linear and nonlinear interactions. And Matt's already provided examples of some of that work. So I'm optimistic that with the combination of these enhanced data methods and analytic methods, that we'll be able to explore these causal pathways more rigorously over the next few years, with funding, of course.
Thank you, Patrick. Our next speaker is Karen Monson, who is an assistant professor at the University of Minnesota School of Nursing. Her expertise is in public health nursing and nursing informatics. She currently leads Omaha Systems user groups in Minnesota. She will be joining us remotely via WebEx. So hopefully the technology is about to create its magic.